Hi rehabbers, it's Kevin from the Rehab Revolution YouTube channel, and this week's learning is about vertebral compression fractures and how to use MRI to assess them, and hopefully some points to look at for helping us distinguish between osteoporosis and malignancy. Now, just before we go on, I am not saying for 1 minute that if you do this and you go through this presentation that you can suddenly diagnose cancer. This is not within my scope of practice or my skill. I generally, as all of the other APs, we have the reports. We are not allowed to report them for the patient. It is coming from a radiologist. And I basically, when I'm practicing, I look at the MRI before I read the report, and then I compare my own report for my learning to the official one, and this is how I learn. So these are just things to help you look at vertebral compression fractures. It does not mean that you can then diagnose the patients. That is really, really important. So, the most common cause of vertebral compression fractures, as it says, is osteoporosis. And it's really, really important that we pick these up. We currently, although getting better, we are not as good as we need to be, because about 30% of these fractures are actually picked up. A lot are self-limiting and the patients just carry on. And then we generally can pick these up later on. So, for example, I've seen patients where we scan and it shows 2, 3, 4 old vertebral compression fractures, and the patient was not aware that they've ever had it. Now, the reason why this is important is the presence of one vertebral compression fracture can increase the risk of having another one by about 5 times, and having 2 can increase the risk of another one by around 12 times. Now, as we said, although trauma is a common cause, and osteoporosis is probably the most common, the incidence of cancers or cancers as a cause of these symptoms always need to be considered in our population. In particular, if patients have had or have malignancies such as prostate, breast, kidney, thyroid, lung, which I use the mnemonic lead kettle, PB for lead, K, T and L to help me remember. If a patient has these or has had them, then it doesn't automatically mean it's going to be that, but we do need to be aware. And as we mentioned there, it's the increased risk of vertebral compression fractures increases, but so does the incidence of fractures as we get older. So as you can see there, under 50s it's about 1 in 8 male and female, and over 70 it's 1 in 5 females. So when we are differentiating vertebral compression fractures of an osteoporotic nature from a malignant nature, there's some things we need to be aware of. So we need to be aware of the signal in the vertebral body. We need to make sure we look at the posterior element of the vertebral body, or the pedicles. We need to make sure, or we look for any spared marrow. Is there any signs of low signal bands parallel to the end plates? Are there signs of soft tissue masses, lesions? Is there a change to the contour of the vertebral body? So is it more convex in nature? Are there signs of what we call retropulsion? Are there fluid signs? So these are all things that you can look for when you're looking at an MRI scan. So the first one, as you can see, we have clearly you can see there is a dark signal change. So this is your normal, that's your normal, and the posterior element isn't. This is on the axial side, so again you can see the dark there, and as you can see from the references above, they find that roughly in between anything from 70 to 95% of patients with malignancy will have a involvement of the pedicle, the posterior elements, which is a lot lower if it is of an osteoporotic nature. The other thing we look for is a low intensity signal intensity band. So that is there, and a nice one picture there. So that is a low signal intensity on T1 and 2, and it's parallel with the M plate. So this is quite a specific sign of benign findings, and it's thought to be the fracture line or trabecular compaction. Now the reference here, so Romeo and colleagues in 2019 found that about 82% of patients with osteoporotic fractures had this low signal intensity band. So starting to look, if they've got the posterior elements, the pedicles involved, and they don't have this low signal intensity band, could that mean that they're more at risk? It's more likely to be of a malignant nature. Whereas if the posterior element and pedicle aren't involved, and there is a presence of a low signal band, then we're looking at, right, is it more osteoporotic? We look as well for this fluid sign, which is more common again in osteoporotic patients, so 35% of osteoporotic fractures versus 2% of patients with malignancy, and this is where it is thought that the fluid from the bone marrow collects in certain areas, and this is what happens here. The soft tissue mass, as we mentioned, so this can be quite a specific finding for malignancy. So you can see here they've got a compression fracture at L3, and you can see on the axial view there's a large irregular soft tissue mass around the vertebral body. And the study by Adele Wanis and colleagues in 2011 found that about 80% of patients with malignancy for their vertebral compression fractures had soft tissue mass compared to 12% of osteoporosis. So we can start to see some patterns. So if we have a patient with the posterior element involved, the pedicles, so the signal changes on both of them, they've also got presence of a soft tissue mass, there's increased odds that it could be more malignant. Whereas if there's no soft tissue mass, there is no signal change to the posterior elements or the pedicle, there's a possible fluid line, and there's a sign of that low intensity band parallel to the end plate on T1, T2, then we'd be thinking it's more osteoporotic in nature. The other thing we need to keep an eye out for is some of the bone marrow being kept. So here you can see this is the abnormal marrow, and this part's abnormal, but under here there is still signs of normal marrow. And what the studies that you can see on the references on the right show that a good 79% to 90%, depending on the study, patients that had preservation of some bone marrow, it was a benign cause of the vertebral compression fractures. So it's always important that we're looking at if there's any preservation of that normal marrow. The next one we look at is the convex border. So you can see here, so instead of it being more or less straight down, it starts to bulge. And this is thought to be due, or related to when the cortex is destroyed by malignancy, the axial pressure down causes the force to move and causing bulging. And this is another finding that can be strongly suggestive of malignant pathology. So again, if we look through, if a patient has the posterior element or the pedicles involved, if they have a sign of this convex border on the posterior aspect, if they have the presence of a soft tissue mass, then it's all adding up to a likelihood that the vertebral fracture is because of cancer. If, however, the patient's posterior element, the pedicles, are normal, there is no convex border, so it's all fine, there's no sign of soft tissue mass, there is some sparing of some of the marrow, there is that low intensity band on T1-2 parallel to the end plates, then these are all suggestive of it not being malignant, but being because of osteoporosis. The retropulsion, which again is a highly specific to benign vertebral compression fractures. So you can see where there is the bulge, and it actually moves superiorly and posteriorly in towards the spinal cord. So you can see that there. And again, this isn't usually a sign of malignancy. So, to conclude our whistle-stop tour, when we are looking at an MRI scan of patients with vertebral compression fractures, then we need to be aware, is there a change in the vertebral body signal? Is there involvement of the posterior elements, so the pedicles and the posterior part? Is there a convex posterior vertebral body contour? Is there that presence of a band of low signal parallel to the end plate? Are there maintenance, or basically is some of the fatty marrow still there? Are there signs of a retropulsed fragment? Is there a presence of a fluid sign? Is there a presence of a soft tissue mass? So as we said, and you can see on there, if we find that they mostly are suggestive of osteoporosis, that's really good. But if we're thinking malignancy, then obviously that's really important that we act on that. And now by that, I mean, if that patient came to me and we had an MRI with those findings, it would have already been reviewed by the radiologist. So I'm not making the diagnosis, that's really important. And normally where I am, it would come up with something like a red star report, and then the job then is to liaise very closely with the GPs, and the GPs usually then do the necessary things. I do not diagnose cancer. I know I keep saying it, but it's really important. This is just a teaching aid, and it's just something I was quite interested in. So I hope you like this last video. If you have any questions, please put them in the comments below, and I will just click onto the references in case you want any further information.